What's up, everyone? Welcome back to my channel Harrison Learns, where we break down complex health topics into digestible bites. Today, we are going to learn about pneumonia based on Harrison principles of internal medicine. Let's jump in. What is pneumonia? Starting with fundamentals. According to Harrison, it is an infection of pulmonary parenchyma, the core tissue in your lungs, which is responsible for oxygen exchange. It's not just one disease, it's classified based on where and how you get it. Key type include community acquired pneumonia, picked up in everyday life outside hospitals, whereas hospital acquired pneumonia develops 48 hours or more after hospital admission, whereas ventilator-associated pneumonia is a subtype of hospital acquired pneumonia linked to mechanical ventilation. Why does this matter? CAP is often come from common bacteria like streptococcus pneumonia, whereas hospital acquired and ventilator associated pneumonia involve tougher, which is drug resistant one like pseudomonas aeruginosa, or MRSA, which is methicillin resistant staphylococcus aureus. Pathophysiology, the why behind the symptoms. It kick off when your host defense fails. Normally, your airways have barriers like mucus, cilia, immune cells to trap invaders. But if they are overwhelmed by a virus weakening your system or aspiration of bacteria, pathogens infiltrate and proliferate in lung tissue. By this, your immune system responds with inflammation where cytokines and immune cells rush in, making alveolar wall and pulmonary capillaries leaky. Then alveoli will get filled with fluid, pro-inflammatory molecules and white blood cells. What is the result? Impaired gas exchange. Oxygen can't get in, carbon dioxide can't get out efficiently. This leads to shortness of breath, low oxygen levels, and systemic symptoms like fever. Harrison notes that this cascade can lead to sepsis if this get unchecked. Okay, if this get unchecked, or especially in vulnerable folks. Diving deep into pathology, pneumonia evolves in stages, classically described for bacterial types like pneumococcal pneumonia. First stage is initial stage, which is congestion phase, where edema with proteinaceous exudate floods the alveoli, which is thick watery swelling. Next stage is red hepatization phase, where erythrocytes, that is red blood cells, will pour out into intraalveolar exudate, giving lung a red liver-like appearance and firm texture. And next stage is gray hepatization phase, where no new erythrocytes enters. Those all already present have been lysed or degraded, and here neutrophil is predominant because white blood cells fights the infection, and there will be fibrin deposition builds up for clotting. Bacteria start vanishing, and as the immune system gains ground. Next stage is resolution phase. Macrophages take center stage, clearing neutrophils, fibrin, and debris. The exudate is reabsorbed, restoring normal lung function. And patterns vary, like bronchopneumonia pattern, which is patchy around bronchi, is more common in nosocomial pneumonias. And lobar pattern, affecting the whole lobes, is typical in bacterial community acquired pneumonia. We will learn about community acquired pneumonia. What is community acquired pneumonia? It is pneumonia contracted outside of healthcare settings like at home, work, or in the community. Unlike hospital acquired types, CAP involves pathogens you encounter in everyday environments. Etiology. The causes of CAP are diverse, and Harrison's categorized them into three main groups. One is typical bacteria, which these are the usual suspects which you might expect. One, streptococcus pneumonia. It is a most common type, often called as pneumococcus. It is responsible for about 20 to 60% of cases. Next is Haemophilus influenza, which is more common in chronic lung disease or smokers. Staphylococcus aureus, rare but serious, especially post-viral infections like flu. Klebsiella pneumonia, linked to alcoholics causing bulky, current jelly sputum. Atypical bacteria, trickier to detect, often milder but persistence. Mycoplasma pneumonia, common in younger adults, causing walking pneumonia. Chlamydia pneumonia spreads person to person, often in outbreaks. Legionella pneumophila linked to water sources. And respiratory viruses, they are increasingly recognized especially post pandemic, which includes influenza viruses, respiratory syncytial virus, and COVID 19, which can predispose to bacterial super infection. Yes. Who is at risk? One is alcoholism, which weakens immune defenses and increases aspiration risk. And another one is asthma, which is chronic inflammation, makes lungs more susceptible. And age greater than 70 years, aging immune systems and comorbidities play a role. And another one is immunosuppressions, conditions like HIV, cancer, or steroid use, lower resistance. And other risk factors are smoking and chronic diseases like COPD, diabetes also play a role. What are the clinical manifestation? First is systemic symptoms like fever, chills, sweats, often sudden with typical bacteria, and respiratory symptoms like dyspnea, shortness of breath, especially on exertion. And another one is productive cough. Example, rusty sputum with streptococcus pneumonia, purulent sputum with Klebsiella. And non-productive cough, mostly common with atypicals like mycoplasma. And GI symptoms such as nausea, vomiting, diarrhea, particularly with Legionella. On physical examination, there will be dullness to percussion over affected lung areas due to consolidation, and there will be increased tactile fremiters, vibrations felt when patient speaks, crackles, which are rails on auscultation from fluid in alveoli. And another one is bronchial breath sounds indicating air moving through consolidated lungs. In severe cases, confusion, cyanosis, or hypotension signal systematic spread, a red flag per Harrison's. Diagnosis is multi-step per Harrison guidelines. Initial test is chest X-ray, shows lobar consolidation for typical bacteria or interstitial patterns for atypicals or viruses. Gram stain culture of sputum identifies the organism such as gram positive diplococci suggest S pneumonia or gram negative rots intact Klebsiella. Blood culture, which is marker for severity or bacteremia, which is positive in 10 to 15% cases only. Urinary antigen test. It detects basically Legionella pneumophilia or Streptococcus pneumonia also. And PCR, which is rapid molecular test, which is done for viruses or atypicals, especially in outbreaks. Additional tests are procalcitonin or C-reactive protein to differentiate bacterial from viral causes, and pulse oximetry for oxygen levels. Management hinges on severity, assessed with CURB 65 score, where C is confusion, U is urea level that is greater than 19 mg per dl, or blood urea nitrogen level which is greater than 20, and R is for respiratory rate which is greater than or equal to 30 minutes. B is for blood pressure, where systolic blood pressure is less than 90 and diastolic blood pressure is less than or equal to 60 mmHg. And 65 is age greater than or equal to 65 years. Now, how do we do scoring? Based on this, if the score is 0 to 1, that is then we will do outpatient care. If the score is 2, then we will do non-ICU hospital admission. If the score is 3 plus, we are going to put the patient in ICU. These tables are taken from Harrison. How are you going to treat inpatient and outpatient both based on their risk factors? First, we are going to learn about outpatient treatment. First, if the patient is healthy, like he or she has no comorbidities or risk factors or antibiotic resistance, you are going to treat them monotherapy with doxycycline or monotherapy with macrolide like azithromycin, or you are going to give them a combination therapy with amoxicillin with a macrolide or doxycycline. Okay. If the patient has comorbidities or risk factor for antibiotic resistance, you are going to give them a combination therapy with amoxicillin or clavulanate or a cephalosporin combined with either a macrolide or doxycycline, or you are going to give them a monotherapy with respiratory fluoroquinolone. If the patient is inpatient, like he has been admitted in a hospital, then how are you going to treat them? First, if the patient is non-severe and patient has no risk factors, then you are going to give them a beta lactam plus a macrolide or a just monotherapy with respiratory fluoroquinolone. If the patient has prior respiratory isolation, then add coverage for methicillin resistant staphylococcus aureus or pseudomonas aeruginosa. If the patient has recent hospitalization or antibiotic treatment, then you are going to add coverage for methicillin resistant staphylococcus or P. aeruginosa only if cultures are positive. If the patient is severe and in severe patient and the patient has no risk factors, it's going to be same treatment like a beta lactam plus macrolide, or now you are going to add a beta lactam to respiratory fluoroquinolone. But if the patient has prior respiratory isolation, same, add coverage for methicillin resistant staphylococcus aureus or P. aeruginosa. If the patient has recent hospitalization, antibiotic treatment, then you are going to add coverage for methicillin resistant or resistant staphylococcus aureus or P. aeruginosa. We are going to learn about ventilator-associated pneumonia. It is a subtype of hospital acquired pneumonia which occurs on patients who have been on mechanical ventilation for at least 48 hours. It basically it affects 10 to 20% of ventilated patients with high mortality rates up to 40% if not managed promptly. Unlike CAP, VAP involves multi-drug resistant organisms, making it trickier to treat. The culprits in VAP are often more aggressive than in community settings. From the Harrison, the most common pathogens are Pseudomonas aeruginosa, which is gram-negative rot, notorious for biofilm formation on endotracheal tubes, and methicillin-resistant Staphylococcus aureus, which is gram-positive, resistant to many beta-lactams. Most common risk factor it is obviously endotracheal tube, because which this bypasses natural airway defenses, promotes aspiration and allows biofilm growth. And additional risk factors are prolonged mechanical ventilation. Should be greater than 48 hours maximum. And advanced age also, coma, immunosuppression, chronic lung disease also. And hospital factors like ICU workload, prior antibiotic use also, which promotes antibiotic resistance. What are the clinical manifestations? The systemic signs are new or worsening fever, leukocytosis or leukopenia, and there will be increased respiratory secretions. And other clinical manifestations are worsening oxygenation, and there will be new infiltrates on chest X-ray. Okay, what is a diagnosis? Obviously, the initial imaging is chest X-ray, which looks for new or worsening infiltrates, consolidation or cavitation, and you can do bronchoalveolar lavage, which is preferred for quantitative cultures for bacteria to distinguish infection from colonization. There are other tests like blood cultures for bacteremia and procalcitonin to guide antibiotic duration. Endotracheal aspirate if bronchoalveolar lavage is not feasible, then we can do endotracheal aspirate. How are you going to manage this VAP? If the patient has no risk factor for resistant gram-negative pathogen like Pseudomonas aeruginosa, then you can give them piperacillin tazobactam. This is a main preferred drug, and you can give them cefapime or levofloxacin also. If the patient has risk factors for resistant gram-negative pathogen, then you can give them double coverage such as beta-lactam like piperacillin tazobactam combined with gentamicin, which is aminoglycoside. If the patient has risk factors for methicillin resistant staphylococcus aureus, then you have to add vancomycin or linezolid to the above drugs. Remember, for the patients with risk factors for MRSA, always include vancomycin or linezolid. Thank you so much. If you like the video, subscribe and share. If you have any doubts, please comment. Goodbye.